Fantastic. Well, thank you all for listening in. It's been an awful adventure in some ways with COVID-19 and discovering that actually COVID patients have a lot of problems with thrombosis. So I'm going to take you on my own personal journey. There is science here, but there's also a lot of conjecture because we don't have all the answers. And I'm going to tell you at the end what Ralph Fiennes is doing in the story that I have to tell you. So, just to remind everybody that hemostasis clotting developed as an effective system of the immune response. What does that mean? It means that the primitive organisms involved a way of walling off bacteria, and they do that through laying down fibrin, which is what coagulation does. And the other thing that we seem to have forgotten is that if people have profound inflammation, they get local thrombosis in the little vessels where there is inflammation. And we know that, and we treat people who have vasculitis. And we treat them with anti-inflammatory drugs rather than anticoagulants. We give them anticoagulants, but we don't expect them to get better from the thrombosis with it. It's the anti-inflammatories that work. And then the last thing to say is that if you're really short of oxygen, which is what you see in COVID pneumonia, it does make your blood very sticky because hypoxia switches on hypoxia inducible transcription factors and they bind to the coagulation proteins and upregulate those that promote clotting and downregulate those that break down clots. So just a reminder about COVID. This is calls to Newcastle for the virologists, but not everyone is a virologist, so let's do it. So COVID binds to cells through the ACE2 receptor, and it binds to the nasal epithelium and the pulmonary epithelium, and also endothelium within the body. And they express ACE2 receptors. The interesting data on ACE2 receptors that's come through recently is that there's a very low expression of ACE2 receptors on nasal epithelium in children and very high in adults, and it increases with age, which is one of the reasons probably why the older you are, the more likely you are to have a bad time with COVID. And also it varies between different ethnic groups, and it's certainly higher in many of the BAME groups. So again, another factor perhaps explaining why we see more BAME patients. Thankfully, most people who have COVID either have an asymptomatic time or they have a minor infection. And that original description of fever and flu-like symptoms has other symptoms joining it, such as anosmia, headache, myalgia. Unfortunately, in this country, about 5% will go on to get COVID pneumonia. And we know the risk factors are increasing age, obesity, and cardiovascular comorbidity. And those patients have a profound inflammatory response in the lungs. And there's a cytokine storm, macrophages are activated. And it's those patients that have been coming into hospital in the first wave because they need oxygen, because they need either oxygen delivered through nasal cannula, or they actually are so bad they need mechanical ventilation. And we know that one of the effects of the inflammation is that we get this amazing signal to the liver to produce more coagulation factors due to IL-6. I hope my slides are all changing with what I'm saying. Are they, Chris?
They are.
Yeah, good. So an issue I think that's interesting is that many of the states we see who have increased risk of COVID have a pre-existing inflammatory state. So let's have a look at obesity. We know that 75% of those we see on the wards who are being ventilated are obese. And we know that in obesity, the adipocytes are switched on in a different way. They produce cytokines that are much more pro-inflammatory, so they're going to add to the pro-inflammatory state. And we know that they express the ACE2 receptor. So COVID is sitting in the adipocytes, probably switching them on to produce more inflammatory substances. And they also produce factors that cause a prothrombotic state. So let's look at the patient journey and think about their risk of venous thromboembolism, by which I mean deep vein thrombosis and pulmonary emboli. So we get somebody who gets COVID, and then 7 to 10 days later, they may or may not get COVID pneumonia, and then they would be hospitalized. Well, in wave 1, they would be. Wave 2 is going to be different. And they will be on the ward receiving oxygen or ventilated. And so they've got a risk of having deep vein thrombosis, because there are 3 factors we worry about, that known as Virchow's triad. They've got increased immobility, they've got incredibly sticky blood, and the lining of their blood vessel, the endothelium, is also altered by COVID. And that risk of having clots extends to 90 days post-discharge. You go home, and then a few of them are having late sequelae who haven't actually had COVID pneumonia. And there are things such as COVID toes, where you get a rash on your toes. So we've got maybe increased risk during that period of immobility. And we have had a few people who've had DVTs during lockdown. People have put on weight, they've done very little exercise, and so that increases their risk. Then we've got hospital-associated clots, and maybe they're going home with increased immobility. We have to remember the average length of stay for someone who's ventilated with COVID is probably over 3 weeks. And they're losing a lot of muscle bulk. They're very debilitated, so they're not going to be doing that much when they get home. And then the other thing that's come through over the last few months sitting in clinic is that some of the patients chose not to come into hospital. And I've had nurses and doctors say, well, I was really unwell, I didn't want to go into hospital, so I stuck it out at home. And some of them will describe they couldn't get off the bed because they were so breathless, and they were rushing to the loo because COVID does give you diarrhea as well, probably got a little dehydrated, and some of them have had clots. And it's not clear what the size of their risk is. So here we are. This is the traffic lights for admission with COVID-19 at Guy's and St Thomas's early on in the first wave. And the more short of oxygen you are, the more likely you end up being ventilated. And what I want to talk about, and we'll talk about a bit more at the end, is the care is going to change. So we are now offering hospital at home care, and they would get similar care, get home oxygen. Those, obviously you can't ventilate someone at home. So what do we find when we look at histopathology? Because of course histopathologists know all the answers. And we find that when we look at the lungs of those patients that have died from COVID pneumonia, they are full of areas of microvascular thrombosis. And I did say at the beginning, perhaps we should have expected that, because that's what inflammation does. And these patients are dying of acute respiratory distress syndrome when we know that they get microvascular thrombosis, but the extent of the thrombosis appears in several papers to be more marked than those who died of other causes of acute lung injury. And then when we look at the changes in these patients as far as coagulation is concerned, they really have incredibly sticky blood. So if we look at the first diagram, looking at Klaus fibrinogen, you and I sitting here should have a Klaus fibrinogen of 2 to 4 grams. These guys, whether they had a clot or not, had really high levels of the median of about 6 or 7. And we have actually seen one with a fibrinogen of 14 grams. And then the second is the D-dimer. Now D-dimers, this is a logarithmic scale. look at the size of the D-dimers in these patients. We use D-dimers if you've got a normal one to exclude VTE. If you've got VTE, you have high values, but these levels are astonishingly high. And then if we look down lower, we've got procalcitonin, very much raised. And then the amazing work that Viapath did to get COVID ferritin set up. Sally was amazing here. We got really fast turnaround time, ferritin set up. Look at the height of the ferritin and look at the height of the CRP. And fibrinogen, procalcitonin, ferritin, and CRP are all acute phase proteins, and they're running together. So this is interleukin 6 telling the liver to chuck out more protein synthesis. Now, this is not disseminated intravascular coagulation, by which the Chinese had labeled the coagulopathy of COVID very early on. And for us academics, we were having to fight everyone saying, oh, it's DIC. It's not DIC. This is an acute inflammatory state. So we have got lung thromboembolism being seen in COVID, and we're talking about COVID pneumonia. And we are switching on, as I said before, all three aspects of this triad of Virchow, who said in 1858 there are these three risk factors for venous thromboembolism. So we expect to see more venous thromboembolism, and indeed we did. And the other issue is that we've got this local thrombosis that we have started to call immunothrombosis, because it's a consequence of local inflammation. And when we look at the pathogenesis of immunothrombosis, the endothelium is very switched on. It's probably expressing tissue factor. And we've got many other mechanisms that the clotters know about, such as netosis, when the neutrophils die and they extrude their DNA, which is very, very sticky. So we were all getting very happy that we had this amazing prothrombotic state due to this inflammatory reaction to the pro-inflammatory state, when a couple of papers popped up very early on. This one was in April in the New England Journal, saying, hey, some of these patients have got antiphospholipid antibodies. And they described 3 patients who had all sorts of problems: hypertension, diabetes, stroke, cancer, who happened to have cerebral thrombosis whilst they were very sick. And they said, well, they've got antiphospholipid antibodies, and this is a major factor in COVID. But actually, this is an extremely poor paper, wasn't reviewed. I've spoken to the New England Journal people. They just put it out there, as everyone did early on with COVID. Anything that was COVID related got published. They didn't actually measure the antibodies properly. We don't know what the levels were. Why did they pick these 3 patients? Had they looked at 60 and then just found 3? And we know that transient antiphospholipid antibodies are common anyway in the acutely ill. And these 3 patients were at high risk of having stroke anyway, because they were so very sick. We know that if you're very sick and you've got cardiovascular risk factors, you've got a high risk of stroke with an acute inflammatory illness. But the other thing that was true was this very high level of D-dimer. Now we measure D-dimers and we use it to exclude pulmonary embolism if the results are normal. But we know that D-dimers go up and down with inflammatory states and with pregnancy. And if you have an operation, and virtually if you go for a run, you will have higher D-dimers afterwards. So this is some of the Chinese work, again from early on, looking at the levels of D-dimers in COVID patients who had respiratory failure versus non-COVID patients from the previous year who also had acute respiratory distress syndrome. Just look at the bottom figures. The D-dimer values were both high in both of them. So this is really a marker of lung injury. So why are D-dimer levels increased in COVID pneumonia? Now, the assumption was made that they were clotting away and it was coming from the coagulation system, and everyone was saying, oh, we need to give lots of heparin to stop this. And we call that secondary fibrinolysis when we generate thrombin and it goes to the endothelium and stimulates more tissue plasminogen activator release from the endothelium to produce more plasmin, which breaks down the fibrin clot. But actually, there is data from acute lung injury data that we have high levels in acute lung injury. And actually in acute lung injury, the hallmark is you're laying down clot outside the blood vessels. That's one of the markers. You need something to break down the clot. And the pneumocytes themselves will produce an activator of plasminogen. It's called urokinase. And we know that in mouse model of SARS, which is obviously very similar to SARS-1, if you give bigger doses of SARS, you get more urokinase production. The pathway isn't well understood, but it does look like the D-dimers might be spilling over from the pneumocytes in the lung. And the other cell that might be producing an activator of plasminogen of the macrophages. I'm sure the histopathologist will tell you if you look at COVID pneumonia, it's stuffed the gunnels with macrophages, and they can produce plasmin by a couple of mechanisms, which includes grabbing passing fibrin and pulling it in and breaking it down with their very good enzymes, and then chucking out the breakdown products, which of course D-dimer is. So I talked a bit about the coagulopathy and what we see. What else do we need to talk about? Well, these patients were clotting. So normally we would give thromboprophylaxis to ward patients if they had risks of thrombosis, and also critical care patients. And the critical care physicians were all saying, Beverley, what are we going to do? They're all clotting, all the lines. So some of them were having to be dialyzed because their kidneys have failed. All the lines are clogging up. What are we going to do here? And then there were huge numbers who appeared to have pulmonary emboli. Well, so let's look at the evidence that we have for using thromboprophylaxis. So in NHS England, everybody, according to NHS England, has to be risk assessed when they come in. And if they've got any risk factors, and risk factors include age over 60 and acute inflammatory illness, and the COVID patients would be included in that, has to get a low molecular weight heparin. And this is really a summary of the low molecular weight heparin trials done at the turn of the century. They all gave low molecular weight heparin, and they reduce your risk of having a hospital-associated thrombosis by about 50%. So patients move from the ward to critical care, where they have much bigger risk of clots because they're much more immobile and they're usually a lot sicker, which makes their prothrombotic state even worse. So we know from big trials, and this is a meta-analysis of 7,000 patients who are in randomized controlled trials, that again, if you give thromboprophylaxis with small doses of heparin in critical care, you're reducing the risk by 50%. And when we know that low molecular weight heparin is better than old-fashioned unfractionated heparin. So let's look at some of the data that we've got very early on. This is data from Wuhan. And when we look at it, it's very clear that they've been looking at the use of heparin in patients who are in critical care with COVID. And they are clearly, unlike us and the rest of Europe, not using standard thromboprophylaxis. So when they gave the heparin to patients on critical care, they had an improved mortality. And you have to think, well, why weren't they giving it in the first place? Because the international literature is overwhelming. And the second issue is we don't know which heparin and the dose, and why the patients who received heparin received it. But nevertheless, we were desperate. This would never get accepted normally. We were desperate for data, and so the journal published it. And the Journal of Thrombosis and Hemostasis that published it is a good journal. They just wanted the data. So the next issue is, well, what are the rates of thrombosis in these patients in critical care? And this data comes from Amsterdam, Saskia Middeldorp, very well respected, and they looked at a snapshot of patients on their critical care over about a week, and they looked at the rates of thrombosis. Now, when we look at this, we've got a graph on the right, and you can see the different types of thrombosis that we see. So they were scanning for deep vein thrombosis, and they were also doing something called a CTPA, which is a CT pulmonary angiogram to look for changes of pulmonary emboli. And when we look at them, we find a fair number of patients will have a big clot centrally or in a whole lobe of pulmonary angiogram, but all of their patients had tiny, weeny little clots. They were segmental or subsegmental. Now, what does that mean? We too looked at our patients in the first month. So we looked at 66 critical care patients. They all received thromboprophylaxis, and we discounted the segmental and subsegmental PE, and we found that our rates of overall of venous thromboembolism, which is DVT and PE, were about 5%, because we felt that those tiny little changes that they were seeing on the pulmonary angiogram weren't pulmonary emboli, they weren't coming from the legs, but they were probably reflecting local thrombosis, immunothrombosis, because these patients had acute respiratory distress syndrome. So now we have got this huge amount of data. This is all the papers and looking at the rates of venous thromboembolism, by which they mean looking at the scans in patients in critical care who've got COVID. And what you can see in the second column is that we've got purported rates of VTE up to about 79%. That's a French study near the bottom. Almost all of them, except for the Chinese, are using thromboprophylaxis, although different types of low molecular weight heparin. And at the bottom is our data, because we have removed those patients who have got mainly segmental, subsegmental changes, and we have a rate of 5%. And we think that actually almost all of them were picking up this immunothrombosis, but they weren't fully recognizing it. So we have got patients who have been on critical care. They finished, they're recovering, they're going home, really disabled, poorly mobile. They need rehabilitation. The question that a lot of people have been asking is, should we leave them on anticoagulation for a period after they have been discharged? And we call this extended thromboprophylaxis. And this is done in the States. They've got drugs licensed to do this, and they certainly reduce the rate of venous thromboembolism a little bit more, because many people have clots after they go home. But we don't do this in Europe because the cost of doing this is considerable. So when we look at the criteria, this comes from really the world expert on extending thromboprophylaxis. The indications are age more than 75, or many of the COVID patients were pretty old. And then extra risk factors, D-dimers greater than twice the upper limit of normal. These patients had D-dimers more than 100 times normal and intensive care stay. So many units are starting to use extended thromboprophylaxis. They're sending patients home on some form of either low molecular weight heparin or a DOAC such as rivaroxaban or apixaban. Now, I have to say, it's been like the Wild West out there as far as what each hospital has been doing as far as thromboprophylaxis is concerned across the UK. Many critical care units saw this high rate of changes on the CTPA and have put lots of patients on full dose low molecular weight heparin or unfractionated heparin. And so we did some international guidance to try and help people. There was national guidance written, sponsored by NHS England, but we submitted it. They asked a group of us to do it. We submitted it in June, and they didn't manage to get it published or on a remote website until August, which really was too late. Everyone is doing their own thing. So at this current time, there's a team of us who've got together, reviewing the evidence again, and coming up with some new guidance for thromboprophylaxis for the second wave. Now, when we did the first wave, we have to remember that at St Thomas's, there were 190 patients being ventilated at the peak in April. And we have a critical care with a maximum number of about 40 beds. So many of the staff were redeployed to work on critical care, and they weren't used to it. So we produced cards to help them. So this is a very simple card talking about routine hematological management, not to take too much blood, because the major cause of being anemic in critical care is phlebotomy. And it provides the thromboprophylaxis dosing. This is really useful for young doctors or consultants who've not been in critical care for many a year. But we're in a stage now when internationally we've got lots of research going on, but we don't have all the answers. So we don't actually know what the background rate of clots in critically ill patients is at this time, which isn't good. You can't do a good comparison. We think that the rates of thrombosis in the COVID patients are higher than others, and I suspect they probably are. We're about to publish some work on that. And we think that there's been some mistakes made, not mistakes, but just misdiagnosis of the fact that some of the things we're picking up on the scans aren't what they say they are. And they're not necessarily pulmonary emboli, but immunothrombosis. And then with the thromboprophylaxis, we don't know what amount of thromboprophylaxis to use. In critical care at the moment, we're using higher than normal doses of low molecular weight heparin because we're so worried. Should we add in intermittent pneumatic compression, which is, as you know, you use this and it squeezes the legs. It's like having rubber balloons around your leg, and they squeeze the leg and push the blood up the leg. Should we use extended thromboprophylaxis? And then the other really fascinating issue is this immunothrombosis. This is a result of inflammation. We now know from the recovery trial that dexamethasone reduces the mortality in the COVID pneumonia patients by a third. I suspect it will reduce the rate of immunothrombosis as well, and the Oxford group are looking at that. We've got some international guidance, but it's only based on evidence that doesn't have a lot of answers, and so it's consensus guidance. So in the UK, it's been fascinating research-wise because the Chief Medical Officer vetted every application for research and has only allowed 2 big trials. That's the recovery trial, which looks at the ward patients, and then REMAP-CAP that looks at the critically ill patients. Anybody else who put in applications, and boy did we put in applications, got pushed away. Suddenly, the Chief Medical Officer has got really interested in anticoagulation. We have already established what we call an anticoagulation arm on REMAP-CAP. So this is what we call a platform trial, and you have multiple arms, and you might compare the antivirals versus no antiviral, and dexamethasone versus no dexamethasone. And we now have an anticoagulation arm out comparing full dose heparin with standard of care. And we have 190 patients randomized so far, mainly in the north, because that's where COVID is worse. And we're just about to add in an antiplatelet arm where we're going to compare aspirin or clopidogrel versus no antiplatelet agent. But we are delivering care in a different way this time round with this second wave. So it's an interesting disease. When patients are really sick in critical care, virus is usually no longer there. And it's the inflammatory response which is doing so much harm. So here's a list. This is the card that's going to go out for medical patients. We need to make sure they're not dehydrated. Many of them were really dehydrated when they arrived with a high fever. They need oxygen. We give them antivirals if necessary. And this amazing ability we have now to give them dexamethasone to produce a better outcome, anticoagulation because of their clots. And then we try and put them in the clinical trials. But here is a new card. This is COVID-19 for the home team. So this time we'll be managing some of the quite sick patients at home. They need mechanical ventilation. They will come in and they are going to get the same treatment as if they were on the wards here at Guy's and St Thomas's. Really exciting to deliver care at home. So I said that I'd tell you what Ralph Fiennes has got to do with COVID. Well, David Hare, who wrote this play, Beat the Devil, about his time with COVID. He had really bad COVID at home. He lost his sense of taste and smell, and everything tasted of sewage. And then he talks about his period with COVID and goes on to talk about the government. And he heard me on BBC Radio 4 talking about COVID and talking about sticky blood. And poor Ralph Fiennes, every night this is on, has got to talk about me and also advertise the fact that patients with COVID have sticky blood, and which is really very, very good for improving awareness of venous thromboembolism. So my take-home messages are COVID-19 pneumonia causes this very sticky blood. We are seeing high rates of venous thromboembolism and also this immunothrombosis. They require thromboprophylaxis to reduce the risk of thrombosis, so they are not clear what the dose is, and the dose and duration will be determined by clinical trials. And I'm going to end on that note, and we'll take any questions, although I think we've rather overrun the time. So thank you for listening.
Hopefully, Beverley, you don't mind hanging on if there are any questions.
Not at all.
Thank you. There's still 42 people keenly listening. So has anyone got a question that they'd like to pose for Beverley? Please either put your hand up or pitch in. While they're thinking about that, Beverley, I'm just going to ask one just for somebody who's not as educated as everyone on this panel. The fact that we had so much in the way of hypoxia clearly obviously has the related aspect of hypercapnia and increases in CO2, not being able to blow that off. Did that cause any particular problems? Because we don't seem to talk about it at all in the acidosis.
So there you have it. That is a profoundly good question, because I forgot to say these patients don't have hypercapnia. So when they were admitted, they'd be sitting there quite happily in the emergency department, but just as soon as they started walking, they were breathless. And so you didn't expect them to be severely hypoxic, but they were really hypoxic. So they're not hypercapnic, they just have low O2, and which allowed them to be happy and stay at home for longer than you would expect.
Interesting. Yeah. Thank you. There's somebody's put their hand up, which is Liz Adair. Liz, would you like to come in?
Yes, thank you very much, Beverley. That's really interesting, although I can't confess to understanding every single thing that you spoke about. I wondered how you were interacting with GPs, particularly as care is changing to nursing patients in the home setting as opposed to coming into hospital, and the risk factors that you've described in your presentation.
So those patients managed at home will be managed by the hospital consultants. And I think that the GPs have had a very bad deal because they've been excluded from testing and tracking, because the government have gone to Deloitte and the private companies to deliver the testing, and they haven't used NHS England to do that. So they're a little bit out of it. I've done, this is my, I think it's my 38th or my 39th lecture on COVID and thrombosis, and I have done about 3 or 4 to GPs, and I've got one next week. So I am a little bit worried that we need to tell them more, we need to pull them in a bit more. Good question.
Thank you. Liz. The next question I've got here is one that's been typed up by Toby, and then I've got a couple other people. Thanks, Beverley. You mentioned that things such as CRP are raised. Do they return to normal or stay elevated for a longer period of time?
So they, we're following the patients out, and the D-dimers do remain very high. I'm not so sure the CRPs do, and I think the ferritins tend to settle, but I don't know the full answer to that, and I will find out.
Thank you. So, and Colin Stone. Colin Stone has got a question as well. I've got one to answer, Annalee.
Yeah, hi Beverley. Thank you so much for that fascinating presentation on this. I've just got a question about long COVID. Is there any sort of idea on whether long COVID is still like an immunothrombosis, inflammatory effects, or active process, or is it more people are recovering from the trauma of having the severe symptoms of COVID?
Okay, so I think one of the problems with COVID is that everyone's treating it as this amazingly new disease that we have never seen before, but you do get post-viral fatigue after a lot of illnesses, and if you think about glandular fever and situations like that. So I'm not clear, and listening, there was one program on Radio 4 the other day about it, that it's any different from standard post-viral fatigue that you see in individuals. And then the other thing I would say, that if you do have COVID pneumonia, it will take such a long time, a couple of months, for the lungs to get back to normal. And we have I see a lot of pulmonary emboli, and some people after pulmonary emboli feel dreadful for a couple of months as they are slowly healing up their lungs, and others feel fine. So I think it's something to do with those individuals, that they have a tendency to post-viral syndrome, really, rather than anything else. But I'm sure we'll learn more about it as time goes on.
Thanks.
Let's just see. There's another question there. This is from Pauline Bigsby. Are the thrombosis rates similar for patients already on long-term anticoagulants as opposed to those with new clots?
So there's data that's come out of New York that shows that those who are on long-term anticoagulants actually have a lower rate of thrombosis in hospital than the other patients. They do very well.
Thank you. And Guy Orchard. I don't necessarily have to ask all these questions if those want to ask themselves. So we've got ACE2 is not expressed to the same degree in various tissue types. The cutaneous red toes reported suggests ACE2 involvement. ACE2 is not expressed in skin. So the dermatological features are presumably inflammatory reactions as opposed to the virus itself, question mark?
So the COVID toes and the fingers, the biopsies have shown local microvascular thrombosis, and when you do immunostaining, I know that people find deposition of antibody and complement. So it seems like it's a late reaction to COVID. It's an immunological problem, and I just wonder if there isn't some molecular mimicry going on, so that those endothelial cells in the fingers and toes might bear similar antigens to COVID, And so, and for those patients, they've got ongoing antibodies, and they bite their fingers. But that's just my own hypothesis. I don't think anyone's quite sure what's going on, but definitely they've got local complement and local antibody deposition. It's an immunological phenomenon.
Thank you. So that was a thank you from Guy for that answer. Can't see any other questions. Is that related to this Kawasaki disease that we're seeing in children?
Yeah. So that's hyper-inflammatory syndrome, much as we sort of see in the lungs in adults. The children get much more severe myocardial involvement. So COVID does involve the myocardium, and they seem to get really bad involvement there. And yes, a Kawasaki-like picture. And it's a plug for the Grand Round. Not next week, but the week after, the paediatricians are going to present on the children's hyperinflammatory syndrome. Anyone can dial into Microsoft Teams, and you're all very, very welcome.
Thank you. That's a good plug. Thank you for that. I suppose I've just got one until another question comes up that just is out of interest. And I don't know what your opinion is on this one. Is how early do you think we were seeing COVID cases, or people were getting COVID-19 in the country? Because I think it was earlier, but I don't know if there's any evidence for that at all.
Certainly January, possibly December, even possibly November, I think.
Thank you. Because if you were to ask me today, the symptoms that I had in late December, I would have said, knowing what COVID is, I would have said definitely I had COVID then. But I recognised it.
Have you had antibody testing?
Not yet.
Well, you must.
I think I will. Thank you. Are there any other questions from the group? Please do put your hand up if you have a question. If not, we can look to close. No more questions are coming up.
Okay.
That was fantastic. Thank you very much for taking the time for all of us. We really appreciate that.
Well, I have to say, you've all been absolutely amazing during this outbreak, and it's a big thank you from me as a clinician to all of you, especially the Ferritin. It made such a difference. People were giving anti-inflammatories because of the Ferritin, and the fast turnaround times that were done for lots of assays. Thank you all very, very much.
Thank you. They'll really appreciate that. Everyone appreciates that. Thank you again.
Okay, thanks.
It's really fascinating. Thank you. Thank you, everyone else. Bye-bye.
Thank you very much, Beverley. Bye-bye.
Bye.